Hi, Meg.
Hello, how are you doing, Dr. Aimee?
I'm doing great. Call me Aimee if you want.
I had so many people message me when I started doing these lives saying, make sure you reach out to Dr. Aimee and to
Yeah.
Aimee because this is just a wealth of knowledge. So I really appreciate it.
Oh, thank you.
And I know you're very, very busy. So I'm going to get right into the questions because I had a lot of people send me great questions to chat with you about. But first, I mean, just getting to know you a little bit, letting people get to know you. So you've been in this field for over 20 years, your website said, but can you tell me a little bit about what inspired you to go into fertility care specifically?
Yeah, I mean, it's just a personal journey. It has to do with my mom. My mom had many miscarriages. I knew when I was 3, I wanted to be an OBGYN. I know that's hard to believe. I knew when I was 12, I wanted to be a fertility doctor. So the office that I'm sitting in right now, this space, is the same office my father worked in for over 40 years. So I started working for my dad when I was 12, and my mom had many miscarriages, even like late second trimester miscarriages. And she's one of the strongest women that I've ever met in my life. And I would just hear her howl in the middle of the night. And I said, I need to dedicate my life to helping women who are suffering with this problem. And so I did a bunch of research on recurrent pregnancy loss in between college summers, between summers in med school. I'm super obsessed with helping people have healthy pregnancies. That's a good obsession. Might seem not like a good term, and I'm okay with that. But
I
I run at 100%, and I'm obsessed with helping each and every person that I meet.
I value that so much because my issue is recurrent miscarriages, and I think that in the community, we hear a lot about getting pregnant, but it can be challenging to find somebody who also, doesn't leave you at 9 weeks and says, we're focused on keeping you pregnant. And that's the goal, is getting to the end with a healthy pregnancy.
Yeah, I used to tell people I'm like herpes. I'm always with you.
Yeah.
That's not so much a compliment. So now I changed my story and I say, I'm like your luggage. You always know where I am. So, like, once you graduate past 10 weeks, just know if there's anything that you need to run by me, just let me know. I don't want to be the person that finds out after the fact that something has happened that was wrong. Like, if you're sensing something's wrong, or if something does go wrong, let me know right away.
That's amazing. And I have heard from your patients as well just how incredibly accessible you are, how you give your direct contact to them so people can reach out right. And I think that's amazing. I'm close friends with a lot of your patients, and
Yeah.
that a lot of people do go to you when they feel like they've kind of tried everything else, or they feel like they're just being kind of given these like cookie cutter protocols that everyone's getting. And that's really not what you do. Can you tell me a little bit about how you make sure you're customizing for each patient that you see?
Absolutely. The first step is come up with a list of what the possible issues are and see what we can do on our own before we start treatment to fix them. So, for example, if you're 43, what do we want to do? We want to support your egg quality. If the sperm is not as good quality, we want to run some extra tests on the sperm before we even start IVF. We want to start supplements. We want to see a reproductive urologist. We want to check testosterone. We want to start Clomid for men. If there's adenomyosis, endometriosis, I don't want a patient learning that after 3 failed transfers, a couple miscarriages. We want to figure that out up front because that's it's going to be part of how we prep for transfer. We may not address endometriosis from the beginning because we might want to do IVF first. But if I were a patient, I wouldn't want to find out these things along the way in piecemeal. I would want to know all of the things up front. And then I design a plan for the patient that will hopefully address all the issues that we know that we have. And then I prepare for transfer. I just don't roll the dice. I present things to patients kind of like a menu, like these are all the things that you can do. And these are the reasons why you might want to choose these and why you might not want to choose a certain option as far as testing. And then we talk about transfer protocols, why I'm going to use what I'm going to use for them, so that they don't have to rely on ChatGPT to explain it to them. And then certainly, like, I love my patients are super educated, and I have a sign in my office that says, "Don't panic, just email me." So it's like there's no question that is stupid, bothersome. There's also no picture that you can't send me. I get patients that send me lots of pictures. I saw this clock. Can I send it to you? I'm like, you don't need to ask, just send it to me. I have a lot of ass pictures too from the Am I doing it right? I'm like, I think I need to delete that from my phone. But yeah, that's my process. And I want to make sure that everyone's really excited for their transfer, that they feel like they're ready for it, that there's no other tests that they wish they had done, that their stress levels are low, they're sleeping well. Because if something doesn't work, I don't want anyone to ever say to me, I shouldn't have done the transfer. I knew that there was more testing that I should have done. I knew that this wasn't a good time because my husband and I are fighting. Those are the kinds of things that I want to avoid.
Absolutely. I love that you bring in too, like external things,
Oh, 100%.
and all of that makes a difference because when you work so hard to make those eggs and make those embryos, it's like the most valuable thing you have, and
Right.
you don't have an indefinite number of them. It,
Yeah. And then I'm going to say something. I think people have to assume that no one cares about you and no one gives a shit anymore. And no one knows your story. And so those embryos are the most precious to you. And just assume that your clinic doesn't value them in the same way. That's really sad to say. I mean, that's kind of like where we've gone.
yeah,
That's not how obviously I feel. Like, when a transfer doesn't work, it haunts me. It's like, what else can I do to help this patient? I know that there are variables that are not in our control. They're like genetic issues that can happen with embryos, even if they're PGTA normal. But I think patients need to learn more than ever now how to be a good fertility patient. And part of that is knowing your own story, knowing your diagnosis, and not relying on the clinic to just know everything about you. So you almost have to remind people what you've been through every time you go to a clinic these days.
yes. And it's traumatic to have to repeat it. And, I've heard you say before diagnosis before treatment,
Mhm.
but that's not the norm in a lot of clinics. Like I've
Mm-mm.
been to clinics before that before they've even met me in person and we're just having a phone consult, they're talking about the protocol they'll put me on for IVF. It's
Oh,
like,
they're even setting the doses. Meg. They're setting the doses for your medications and they've never even seen you for an ultrasound. They're giving you a calendar without even a baseline ultrasound.
right. And then it's like throwing spaghetti at a wall and hoping one eventually sticks. And I'm sure you hear this a lot, but I know a lot of people get very, very frustrated when they're just told, well, it's unexplained infertility. What does that mean to you when you hear a patient come to you and they say, well, doctors have
Well,
told me
the
unexplained?
first thing that I say, bullshit. Okay.
Yeah,
Um,
right?
it means that it wasn't explained enough and not enough testing was done. There's always an explanation. So if let's say you're 38 years old, your AMH is good, sperm is good, fallopian tubes are open, it's age related. Assume it's an egg quality issue, right? If let's say you have euploid embryos and it's not working, you need to look for silent endometriosis, adenomyosis, immune factors, the microbiome. You have to keep looking. There's just no such thing as unexplained. So when a patient gets that diagnosis, don't call them out on their bullshit. What you're going to say as a patient, you're going to say, thank you so much. And then you're going to say, what are the possible explanations in a case like mine? What do you think it could be? Right? Because they're not going to not say anything to you. Well, hopefully they're going to have some sort of answer, but there should be some sort of helpful reply. I asked a patient to do this the other day. It was a second opinion consult. She was having early miscarriages from euploid embryos. And then I asked her, like, what does your doctor think the problem is? And the answer was implantation issues. I'm like, no, I know, but what is causing the implantation issues?
Right.
You know what I mean? And it's like, we need to get to the root cause of what is going wrong.
I really appreciate that because I think whenever I think about even the idea of somebody saying that they have unexplained of any other kind of medical issue, I
Right,
wouldn't take that. My friend who's a dermatologist says no one would come to me and I would say, "Oh yeah, that's an unexplained rash." Like no,
right.
we need to explain it to treat it. Like you
I give presentations to large groups about this, and I make the analogy of exactly like you have shoulder pain, you go to urgent care. What are they going to do? They're going to do an x-ray. They're going to see they're not going to say, oh, it's nothing, just deal with it for a year, and we're not going to do any tests. It's unexplained. That would never happen.
Yeah,
Yeah.
absolutely. And okay, so I love the name of this. I love how you get all these acronyms.
Yeah.
Tell us what the TUSHY method is and
Yeah. Well,
like
it's triple X porn. It's my new website. I'm just kidding. It is
it's where you
not.
get those photos on your phone.
Like, that's where I put all the ass shots that all my patients send me from their progesterone and oil. It is not. I promise you guys, it is not. It's basically me getting sick and tired of patients coming in and saying I had unexplained infertility. And they only had an FSH level checked or an estrogen checked or an HIV level and a blood count. So I came up with the acronym because there are 5 tests you can do. T is for tubes, U is for uterus, S is for sperm, H is for hormones, Y is for your genetics. So most people can get to a diagnosis by doing those 5 tests. So patients can then advocate for themselves because it's easy to remember, right, Tushy? Like, how can you forget that? It makes everyone giggle. So that's why I came up with that. So it's an easy way to remember, get my Tushy checked. And I think everyone should do that, honestly, before you even start your fertility journey. Kind of like the analogy that I share all the time. Like if you're going to make a cross-country trip, you're not just going to jump in your car and start driving. You're going to make sure that you took your car to the mechanic. They checked under the hood. They put gas in. We have to do the same thing with pregnancy. Pregnancy is like one of the most important times in our life. And so I feel like we need to give it that as much attention as we would a trip across the country.
Yeah. It's so funny you mentioned the photos. I'm thinking back to a friend was flipping through my photo album looking at dog photos, and then she got to one, she was like, "What is this?" And I was like, "Oh, that's just blood clots in my underwear. Keep going."
Yeah, you know what I mean? I get those pictures probably once a day. You have to see this clot, Aimee. I'm like,
Right.
okay, what is this white thing that just came out? I'm like, send it to me. I can tell you.
Somebody just asked, the acronym is TUSHY,
Yep.
TUSHY.
All
Um,
my acronyms come with websites. So tushymethod.com. You can go to that website and learn more.
and you did mention one, so I had quite a few people send me DMs asking for you to talk about this. They had an AMH test, and the
Mhm.
number was very low, and now they think I'm hopeless. Can
Yeah.
you explain AMH and what should somebody think about if they do have a low level? What are their options there?
Yeah, so AMH, first of all, I call it always mean hormone. You might have heard me say that. It's mean. It makes us feel bad, but you have to separate the facts from your feelings. Okay? And the thing is that AMH is not a good fertility test. It's the closest thing we have to a semen analysis for a woman. Like I can't give a woman a cup and say, "Here, give me your sperm." But I can do an AMH. I wish I could. I can do an AMH and it kind of tells me how many eggs I would expect from them if I were to do IVF for them. So it allows me to set up what their IVF pyramid would look like how many eggs I would get, how many could potentially be mature, how many fertilized eggs, how many blasts. So then I can make a fertility plan for them based on their age. So let's say you were 38 and your AMH is zero point 0.2 and you want 2 kids. Well, we might need to do 6 IVF cycles. Doesn't mean you have bad eggs, right? It does not. It just means that this is your number and everyone's number is different. And I can have a patient who I get 2 eggs from, I get 2 euploid embryos. I can also have a patient who has 20 eggs and gets no euploid embryos. Isn't that unfair? It's unfair to everybody. And I wish that this was reversible. Like, I wish there was more that I can do aside from some of the experimental things that I'm doing now to help patients. But there really isn't anything that works like 100% of the time to try and reverse ovarian aging. So the most important thing is, get your level checked. Don't take it personally. Do your best to be in the best shape of your life. Take your supplements and go to a doctor that won't shame you and start talking to you about donor eggs and start bullying you about that.
I appreciate that a lot. And you mentioned technology. What are some of the experimental things that you're excited about that maybe we're still trying to understand it, but are tools and resources that you're like, these are things I'm trying and I'm seeing results in?
Yeah. So the first thing is I'm 75 years old. Do I look it? I'm just kidding. I'm not. I'm
Oh my
not. I'm totally. I
God.
got.
I almost said, DM me your dermatologist this moment.
No, I wish I could put a filter on this live. Then I'm even younger. No, I'm 49, and there's a reason why I'm saying that. So I take a repurposed drug called rapamycin. It's 5 milligrams once a week. I've been taking it for over 2 years. I'm not going to share my fertility levels with you because it doesn't matter, but they're crazy good. Like you would never believe. So there is research showing that rapamycin can increase longevity by about 15% in humans. I want to live forever. I know not everyone can relate to that, but I just know that I want to help as many people as long as I can while I'm still here. The reason why I'm telling you about this is that in the animal studies, they noticed that in the animals they gave it to, it reversed their menopause and they had healthy pups. So it was in mice. And then brilliant researchers out of Columbia University did the Vibrant study. And so what they found, they hypothesized, excuse me, that women who took this drug, it delayed their menopause by 5 years. Okay.
Wow.
So my average patient is 42 years old. That's huge. If I can do something to delay menopause and also help you have a healthy baby and improve your chances with IVF, why not?
Yeah.
So it's, off label. It is FDA approved. It is not illegal to use it. It's considered experimental. So you have to be okay with that. There are a couple of side effects. I get some zits once in a while. I get mouth sores once in a while. I don't care. When I see a zit, I'm like, okay, I'm aging backwards. I'm 16 now. I'm
Yeah.
really. But that's one of the things that I have been using in my practice for over 2 years now, since May of 2023. I can't believe it's already been that long. And the second thing that I've been doing for much longer is ovarian rejuvenation, and that's with using ovarian PRP. Then there are other supplements like OVA NAD, red light therapy. Sometimes I ask patients to consider hyperbaric oxygen therapy. I use peptides in my practice. The peptide that I use is sermorelin. I also use HGH. I've been using HGH since probably 2008, so that's nothing new. But those are just some of the things that I've been doing, and I have Google alerts on everything, and I follow longevity medicine, all the newest things that come out of longevity journals, because things that can extend our lifespan are things that can potentially help improve support and quality and potentially help improve a woman's fertility too.
That's fantastic. And some people are asking, just so you know, I will make sure to put this on the website with a list of all these notes and tips and write them all out. So if you miss something or taking notes, don't worry, we're going to have the script go up live for everyone. That's so interesting. I love that you're also using these yourself. So you can speak to what the experience is, what the side effects are. Is there anything that that you hear people recommend that you would say, no, it doesn't work. I haven't seen any good results from it. I wouldn't recommend that one. Anything you see people talk about in the fertility world?
Yes, glutathione, not a fan. Don't think it works. DHEA, forget about it. I think it just raises testosterone levels, not good for eggs. When it comes to transferring, I've seen people use drugs like Viagra, compounded, it sounds sexy. I don't think it helps. Trental, it's a pill. When it came out, we thought it might improve the lining. I don't think so. HCG infusion, I would say no. And of course, I'm not your doctor. So these are the things that I recommend to my patients. So if your doctor, if this is a tool in their toolbox, they're like, I swear by this, then consider it. But these are just, things that I have strong feelings about.
Yeah, absolutely. And I think that a lot of these myths end up costing people time too, right? I think that when people pursue something, you lose precious time. And so we do, as patients, have to make these really, because as they say, 10 different doctors will have 10 different opinions. And so we have to think at the end of the day, like, okay, what am I going to try, knowing that this is going to take months, maybe years, and that time will get lost. What are some other reasons you see people might cost somebody precious time when it comes to infertility treatments, when it comes to trying to conceive, trying to stay pregnant? Where do you see people like, that's time lost? People don't have to lose time.
I would say patients who they have a plan, like they know how many kids they want, but they waste time doing IUIs. So I would say, like, if you're 39 and you want 2 kids, you can still do IUIs, but, preserve your fertility.
Yeah.
Yeah, do a cycle of egg freezing or embryo freezing first. So I think people sometimes think in their head, oh, I have to do 6 IUIs first before I can do IVF. And that's just not true. So it's diagnosis then treatment. So if your diagnosis is I'm 39 and I want 2 kids, the treatment is preserve your fertility.
Mm-hmm.
So I feel like people sometimes waste time with treatments that they're going through additional procedures and treatments that aren't going to be successful for them, especially along the lines of sperm. I hear so many times that, like, a lot, how you said unexplained, like my husband's sperm is low, but it's unexplained. I'm like, why would you do IUIs with low sperm? That doesn't help. So IUI doesn't make bad sperm better. It just doesn't.
Yeah.
IUI, I think, is good for people who fight, around ovulation. I'm like, just take it out of the bedroom, bring a cup to my office. I'll
Yeah.
take it. IUI is good if, like,
Only
there's
for
sexual dysfunction.
her.
Yes. But in general, I think missing diagnosis like endometriosis, adenomyosis can certainly waste years of a patient's time.
So, I have endo and adeno, and I've had doctors say, well, we just keep trying, eventually it works. I've had doctors say, do these other things. How would you approach somebody who has that diagnosis?
Yeah, so the first thing is to see if the endo or adeno has affected the fallopian tube. So endometriosis can create inflammation in the tube. So if it's been over a year since you've had an HSG, that's one thing that I always do. If there's a hydrosalpinx, then I would recommend laparoscopy. If you have symptoms and if there are obvious signs on ultrasound that your ovaries, let's say, stuck to your uterus is severely flexed or tipped back, then maybe you should also consider laparoscopy and not just medical treatment. So I also consider combining both, so laparoscopy and then also medical therapy. If you do laparoscopy and there's no sign of deeply infiltrating adenomyosis and there's no sign of adenomyosis, which is the inflammation in the walls of the uterus, then you can skip medical suppression. No one wants to be made to feel like a postmenopausal or postmenopausal woman, but the reality is sometimes treatment still is required for that. If you have adeno, make sure it's adequately treated. Sometimes 1 month is enough, 2 months is enough. For most patients, 3 months should be enough. And have an honest conversation with your doctor about how severe it is, where it is, and what the risks are going into a pregnancy. So we know adeno can increase risk of implantation failure, miscarriage, second trimester loss, postpartum hemorrhage, and hysterectomy. So I don't want patients to have a bad outcome and then say, I wish I had known that. If I had known that, I wouldn't have moved forward in this way. So typically I offer patients Depo-Lupron or Orlissa.
Mhm.
And for patients who are worried about the mood side effects because they might have mental health issues currently, I recommend that they consider birth control with letrozole daily. I like Orlissa twice a day, 150 milligrams with letrozole, 2 tablets at night, and then norethindrone, 2.5 milligrams at night. I add calcium, NEC, NAD, CoQ10, red light therapy. And then at the 60-day mark, if they have good ovarian reserve, I highly recommend the modified natural FET protocol, even after suppression. So many doctors are like, you can't do modified natural after suppression. I'm like, yes, you can. You're just lazy. Uh, and the thing is, it makes no sense to suppress a woman and then hop her up on estrogen.
Yeah.
Because now you're re-stimulating the inflammation. How the heck, why does that make sense?
Yeah.
Does not make any sense.
Totally. And
Yeah.
how long would you say after doing that somebody has then to try transfer or try naturally after they've done a suppression?
Well, with suppression and then trying naturally, it's tricky
Okay.
because the thing is, suppression takes, it's almost like you need an exorcism by the time you're done with it. It
Mm-hmm.
takes so much out of you physically, it's so draining.
Mm-hmm.
So it's hard for me to recommend suppression than trying naturally because I feel like trying naturally, the likelihood is so much lower than doing a transfer. So I really want, if a patient's going to do suppression, to give themselves the best chance of pregnancy as soon as possible
Mm-hmm.
to take advantage of the benefits from suppression.
Yeah. Yeah.
So,
So right away kind of thing.
yeah. And then within the protocol, sometimes I consider things like tacrolimus, Neupogen, the antihistamine protocol, HGH to help with the uterine receptivity, and Neupogen on the day of transfer and afterwards, in addition to like steroids, aspirin. So those are just, I know it sounds like a lot, but I have a nice spreadsheet, a template, and then I just go through and see what I want to do for each individual patient.
That's great. I'd love to touch on something you said a little earlier, which is how you do feel the heartache of a failed transfer. Can you speak a little bit to when you do have a patient with a failed transfer? What do you do next? How do you decide whether or not to move forward with another, to step back and reassess? What are some things you might look at? And let's say this was with a PGT tested normal embryo.
Yeah. So this is what I teach patients who see me. So I do fertility consulting. So when patients see me, it doesn't mean that they have to come to me as their doctor. So I tell them when you're planning your transfer with your doctor, ask them if this transfer didn't work, what would we do differently next time? Okay. I want my patients to know the answer to that question because I don't want them to wonder, why didn't we do that this time?
Yeah.
Okay. So some of the things that we talk about is if this at the start, because I want them to know that if it doesn't work, because sometimes it doesn't, that there is a plan, there is hope. I'm thinking about things already. Some of the things I think about are some of the additional treatments that I just, talked to you about. I think about maybe transferring, depending on the quality, more than one embryo.
Mhm.
So potentially transferring 2 embryos. If we haven't done some of the implantation tests that I offered the patient at the start, we talk about doing those tests, like looking at the microbiome, looking for silent endometriosis. So, it just kind of depends on what we did previously and then what we want to add. But let's say we did all the tests, but we didn't do, let's say, uterine PRP or Neupogen. Typically for the second transfer, I'll add those 2 things in.
Yeah, that's really helpful. And I appreciate also that thought of approaching it even before. If this doesn't work, what will we do differently? Because I
Yeah,
have had that feeling you've
yeah,
expressed of back and saying, I wish we'd tried this first. I wish we'd done that. And it's such a hard feeling to think
yeah.
that because fertility treatments can be overwhelming emotionally and physically. Do you have any advice that you offer to patients when they're starting the process of how to handle what is to come emotionally and physically?
Yeah. One of my other websites, fertilityteam.com, build your team up front. Therapist, don't stop exercising. A lot of patients stop that, and that's bad for mental health. Find a good acupuncturist. Acupuncturists can be a great member of your fertility team. They're really, really smart. Find a mindfulness practice. And the easiest thing to do is find your happy place. Like I always tell, what's your happy place? Like, do you have one, Meg? I'm asking you. Do you have one? I have one.
It's in my library with my dog who's on my lap right now.
Love it. So
Very-
like as soon as you're stressed, you just go there,
yeah,
and then just get educated.
yeah.
Don't assume that when you walk in that clinic, like we said earlier, that everyone knows who you are, why you're there, what you've been through, what your goals are, what your beliefs are, and what you want to do next. You have to share that with them. So I teach patients to like have a little blurb about yourself. When you send in an email, you just say, I know you're so busy. Just in case, I just want to remind you, this is my story,
Mm,
right?
yeah,
And if you have questions that you want answered at that visit, you can say, just real quick, I wanted to send in my questions ahead of time so you have time to look at them because I know you're so busy and I want to make sure that I don't take too much of your time asking these questions. I just want to send them ahead. So you can do that for yourself. So I think just educate yourself. ChatGPT is a great resource. If the answers you're getting are too over your head, you can literally say, like, you can actually upload all your information, upload your labs, upload your age, and talk to ChatGPT as if you're talking to your doctor
yeah,
and say, like, I'm 37 years old. These are my levels. What are my chances with IVF? What are my chances with IUI? What is IVF? And then if it's too over your head, you can say, please explain it to someone who has like a high school education in terms of science or a seventh grade education in terms of science. Or you can say, please use analogies that are easier for me to understand. And I actually use ChatGPT quite a lot to do that for me because I have patients where they're like, I still don't get it. And I'm like, well, let me come up with an analogy. I suck at analogies. So I'll be like, ChatGPT, give me an analogy. And I present it to the patient and they're like, oh, that makes so much more sense. I totally get it now. So I want you to get it. I don't want you to go into your IVF cycle with unanswered questions. And you just don't know what you don't know. So the more you know, the better things will go.
so true because we don't know what to ask for if we don't even understand it. And there are doctors who kind of tell you, like, get off Dr. Google, but it's like, no, I want to be informed. And I don't have a medical degree, though
Yeah.
I at this point I'm basically a med student because
Well, it's not just the doctors. There's culture in clinics where it's not the doctors answering questions anymore.
yeah, and that is actually is one of my questions, which is in the medical system in general. What is a change you wish you could make so that the whole system is better for women and for fertility patients?
Yeah, that people talk to their patients, they're just not. When patients have failed cycles now, they're getting booked like 2 or 3 months out to review their cycles.
Yeah. If they review it at all.
If they review it at all.
Yeah,
Yeah.
I heard someone even mentioning here going through a failed transfer, and then they just said, "Okay, when your period comes back, call us, and we'll start all over again."
Yeah. And I see message like his patients send me the messages that their clinics send to them. And I'm just like, the reply starts with, you're just getting a lot of misinformation from the web. And
Mm.
I'm like, no, you're just gaslighting the patient to justify why what you're giving to them as the protocol is the only option. And that's just not fair.
I really appreciate you saying that. I've started saying to doctors in general, just everywhere, especially after so much time when we've tried it their way, I've started saying like, okay, I'm going to add this
Right.
because another doctor said it. Don't tell me no, just tell me if you think this will do harm and why. Because if you don't
Right.
think harm, then I want to try it.
Right.
Uh, and you mentioned a few things about, acupuncture. What are some other like lifestyle tips that we can take on right now, no matter where you're at in your fertility journey, that you always recommend?
Listening to EDM music. No, I love EDM. It always puts me in a good mood. Strength training,
Mm,
getting good sleep. So I ask my patients to get the Aura ring.
mm.
do what you can to decrease stress. Make sure you have a healthy BMI, and make sure your relationships are good with yourself first and then with others around you. So if you're partnered, no one goes through IVF to then share a baby with someone 50% of the time. And I see so many couples who go through this journey and they think, oh, having a baby is going to fix the problems that we have. So I think it's really important to do that first. But yeah, I mean, the things that you can do today are follow an anti-inflammatory diet, strength train. I have weights in my office between patients. Patients, if you look around the corner, you're going to see all my weights. I have a mirror there and I just do curls, get your steps in. So those are easy things that you can do.
Also, really great advice, and just really great advice in general, even if you're not trying to get pregnant. Just
Totally.
lifestyle, healthy advice. I am curious, and this is a tough question. I'm sure it really depends on the patient, but is there any point where you might say to a patient, I just don't think this is going to happen?
Yeah.
And what does that look like? What point of the journey is that?
Yeah. So I'll just give you an example. Let's say I have a patient who's like 44 years old, her AMH is zero point 0.1, and she still wants to be given a chance. Well, I'm going to help you. I'm not going to bring up egg donor. Patients know that that's an option. I'll just say to them, the likelihood is not zero, but it's low. And then I'm going to say, let's give this 6 months. Let's do everything that we can. And at the 6 month mark, as we go through the journey, they're going to see it in real life. It's one thing to see it on paper, or someone handing you some statistic and a chart, but it's another thing to live through the experience.
Mm-hmm.
So if you've lived through the experience, because this is such a spiritual journey, then you can see for yourself, oh, yes, this really isn't working. I can now have closure and move on. So at the 6 month mark, I say, let's talk about what we've learned so far. Does it make sense for us to continue? How are you doing? And patients will often tell me when we're at that point where we usually are on the same page, we say, I think I'm ready now. Let's talk about other options. Because I don't want patients to think that I'm giving up on them or I don't believe in them. So that's how I approach things. Same thing for transfers. If I've done all the things, like we've explored everything, and a transfer just isn't working, then usually when I'm ready to talk to the patient about it, because they know that we've done everything, when I bring up the topic of considering surrogacy, they are ready to hear it.
Yeah, that makes a big difference because you always want to at least, I do think so much of overcoming grief and overcoming, even just thinking it's time to get off this hamster wheel is knowing
Mhm.
because everything possible.
Right.
I'm not going to look back and wonder. I won't ask you to violate HIPAA, but do you have any stories where you're like, it worked for someone and no one else believed it would, and you were able to say, like, we made it happen, we did that?
Oh,
Any?
I have stories that I'm allowed to share. I mean, I had a patient, she named her daughter after me, Aimee, same spelling. She tells a story all the time. She went to a clinic and they told her, even if you had all the money in the world to do as many IVF cycles as possible, it'll never work with your own eggs. Okay. Well, she has a daughter named Aimee now. So I didn't, I didn't tell her to name her daughter Aimee. But actually, she has twins. So I got 2 eggs, 2 embryos. I transferred them both fresh, day 3. And I think they're starting 3rd grade. I think I got their first day of school picture today. So that is a true story, and I'm not violating HIPAA. She tells a story, and she actually have a picture of her. She actually gave me 2 roses. There's actually a picture that she gave me that sits in my office just to remind me of that story. And I'll never forget it. I have countless stories. I have a patient, FSH of 119. No joke. And she has, I don't want to share how old the child is because that, I don't think that would be identifying information. But same thing, she wasn't given a chance. The reason why it worked for her, I think, is because she was under 35. And I did a lot of the things that I've talked to you about, like ovarian PRP. We did some HRT, and I was able to get her to ovulate, and she now has a child. I see miracles every day. And I just know that unless you try, you're just not going to know if it's going to work or not. I mean, there are obvious situations where you know it's not going to work. I feel for the woman who comes to me over 50 who still has hope in her heart. But, at this point, I can't do anything to reverse menopause once it's that far.
Where do you see fertility care in the next 10 years? Like, sometimes I feel like it's advancing so quickly, and other times I'm like, gosh, it must be so far behind. And so what do you think 10 years now is going to look like?
I mean, 10 years from now, I think patients are going to be talking to avatars and not humans. I think the majority of people are going to need fertility care because we're being poisoned from the minute we're in utero. I think this generation of children aren't going to have kids until they're in their 50s. So the only way they're going to be able to have babies is if they froze their eggs in their 20s or 30s. And if we are able to master in vitro gametogenesis, where you can take a cell and convert it into an egg. So I think our live birth rate is tanking. You know, you see these stories where people are saying more women over 40 are having babies than, you know, women under whatever age. And it's not because women over 40 are more fertile. It's just because people are waiting too long to have babies and fertility rates are rising. So I think we're seeing higher rates of PCOS, higher rates of endometriosis, and we need to get ahead of it. And I do predict also that you can see I have lots of predictions. I have this crystal ball. And then my other prediction is that the government is going to pay. I know our I won't name his name because I'm a little mad at him right now for reneging on covering IVF.
Yeah,
But I do think as a
come
society,
out of our internet.
I do think that as a society, the only way that be able to continue is if the government steps in and pays for us to preserve our fertility at our young age. Because, you know, 25-year-olds don't want to have kids anymore, at least not in the Bay Area. Everyone waits until they're like, a lot of people wait over 40. And it just makes the journey a lot harder when you do that.
I would love to end with one question, but a couple of people had put some questions in the chat. And what I would say, because a lot of them I did ask throughout, but a lot of them are also very specific medical questions.
Yeah.
Uh, I would say definitely visit Aimee's website because it's a wealth of knowledge and resources there. There's a couple different pages that give a lot of information. But then the advice she gave earlier, which is like plug these questions into ChatGPT and
Yeah.
ask questions with your testing. Put your numbers in there. It's so, so helpful. Before I ask my last question, also, I will make sure this reel is saved on our pages with a transcript so people can find all these notes and tips, which have been so helpful. But I would love to hear from you. I feel this way sometimes. I've been in this for a long time. I've had a lot of losses. So many of the people who follow me have shared this with me. They send me DMs and they're just having one of those days where they feel hopeless, but they're not ready to stop, but they're struggling so much thinking there's a chance. And what message would you like to relay to people who still so badly want to be a parent but are starting to lose hope in it?
You're gonna make me cry. You're making me cry. So the first thing I'd say is hope never killed anybody. You just have to remind yourself of that. It just didn't. It's not gonna kill you. It's okay. And if you have hope in your heart, there's a reason why. I mean, sometimes people are not practical about their hope. You know, they're not hopeful based on there aren't scientific reasons for them to have hope, and that's a different story. So I think you have to ask yourself, are there scientific reasons for me to still be hopeful? Yes or no? If the answer is yes, then just believe in that and keep going. If the answer is no, get help for that, right? So my 54-year-old who still thinks when she's in menopause that she's going to be able to have a baby with her own eggs, like she needs help. Right? She needs help to kind of resolve that and just stop doing what she's doing. I can't get her there. She needs some professional help, right? To make her believe and understand what science can do for her. But I think in general, if there are scientific reasons to have hope, then continues to be hopeful and find a team, surround yourself with people that will cheer you on and not bring you down. I can share the story with you. I have a patient who did 23 IUIs with me. She's 43 years old. She had her baby at 44. I have an oil painting of her daughter that sits on my piano, too. True story. I'm allowed to share this story with you. Everyone told her she was crazy. Everyone told her that she had lost her mind. Her daughter's in the 7th grade, to start school today. So I share that story with you because I have 23 gray hairs from all those IUIs. I mean, if you think about how many years, how much treatment she did, she didn't give up hope. She just believed. And I don't, you know, some people have that endurance and that's part of their journey. And there's nothing wrong with that. It is your journey. So I'll say other bad words. I'll say funk what other people say. It's your journey. It's not their journey. So just believe in yourself. Make sure you have a partner that's supportive. If you have a partner that's a douchebag and doesn't show up and isn't there for you and asking you those three questions, what can I do for you? How can I help you? What do you need? Then really reevaluate your relationship. But that's how I would answer that question.
I love that so much. I have had so many hard moments over the years, and then following you, seeing how you care for your patients, knowing that there are medical providers out there that aren't just doing this because that's the field they fell into, but they genuinely care and genuinely listen, makes me feel more hopeful that I can keep doing this because there
Yeah.
are people out there. Aimee, I appreciate you so much. Thank you so much for taking the time to chat with me, and you will
Yeah.
definitely keep hearing from me a lot.
Thank you. I hope we get to do this again. I just want to do one plug. I also have an IVF class once a month. It's eggwhispererschool.com. And that's an opportunity for patients who cannot be my patient to join. So if you're listening in and you've been adding questions, you're like, I want to learn more. I want to ask her questions about my case. So I run these courses or this class just for folks. It's like a live Q&A, just like we're doing. Like I don't stop the class. The class doesn't end until every question is answered. So I invite people who are interested in learning more about their scenario and they don't necessarily feel like they can do a full consult with me. It's okay. Like you can join the class and I'll do what I can to help you during the session.
That's amazing. I just wrote that down too. And like I said, I'm going to get this saved immediately for Reels because Instagram's great that way. And then we'll have a transcript up really soon. And
Um,
so many good resources, so many good tips. I absolutely love it. Thank you so much, Aimee. And thank you everyone for joining and following along. And hopefully we can all just stay connected and DM each other and keep pushing through everything we're going through.